Hello, my name's Cate Orteu. I'm a dermatologist at the Royal Free Hospital. I have been working with my rheumatology colleagues there, Chris Denton and Raynaud, amongst others, for a number of years, managing patients with systemic sclerosis and morphoea. So I have been asked by SRUK to spend this hour, potentially, or up to an hour, talking about skin health in scleroderma. So I'm here to answer your questions, and I've been sent a few questions already. So I am ready to start with those. And so the first question that I received is a question on what is the best skincare routine for scleroderma, and looking for moisturizers and things to apply to the skin. What's the best moisturizer? So in terms of moisturization, there are lots of different things, and so the best moisturizer really is the one that you like when it comes to, it's the one that you're going to use. And different people like different things. So there are lots of different potential moisturizers, things which are greasier or less greasy. A lot of moisturizers are paraffin based, and occasionally that is an issue. We need to just remember that paraffin is flammable, and so there have been some issues with moisturizers and their flammable nature if they're used in widespread areas on the skin. So the things that I usually recommend, if you need something that's along the sort of greasier end of the spectrum, I usually recommend things like Epiderm, which is comes in a tub and is quite solid, but is actually a very good moisturizer. You just rub it between your hands, warm it up, and then apply it in a downward motion along the limbs, so that you don't cause problems with occlusion and folliculitis, so you don't cause spots by rubbing it down the limb. The next sort of step down, I would say, is something like Diprobase, which is a less greasy, or Diprobase cream's a less greasy moisturizer, which is perhaps a little bit easier to manage on a day-to-day basis and under clothing. And then there are other products. If you're looking for products which are paraffin low in terms of their paraffin concentrations, things like Oilatum cream or E45 cream have less paraffin than some of the others. And then there are a few that are paraffin-free. So things like Neutrogena hand cream doesn't actually contain any paraffin. Eucerin 10% urea lotion doesn't contain paraffin. So there are a number of products that you can look at and choose from. But as I say, the most important thing is that you actually find something that you like and that you use on a regular basis. So just looking at other questions. Sorry, I'm learning around my way around this technology just now. So I have a question from Patricia. So she says she'd like some face serums that contain vitamin C or an AHA tonic such as lactic acid, but don't know if those products are safe for us to use. She says she usually avoids products that boost collagen, but is not sure about any other ingredients in skincare. So I would have thought, I mean, that's a difficult question to answer, but I would have thought that anything with an antioxidant in is unlikely to be harmful to skin in scleroderma, because antioxidants, things that we sometimes recommend for treatment and orally for treatment. So I would imagine that should be fine. But I guess the collagen boosters may not be the best thing to use if you've got systemic sclerosis and you've got facial involvement. So oil-free lotions, I think I've got a message here from Chris. So you may have just missed the beginning of that last question, but things that are oil-free, the moisturization for things is often linked to paraffin. And so some of the things that are have less paraffin content may not be such good moisturizers. However, there are some which have no paraffin content. So Eucerin 10% urea lotion and Neutrogena hand cream are lotions which are or should be relatively safer to use if you use oxygen. But obviously you do always need to be careful. The ones that are lower in paraffin content, E45 lotion, E45 cream, Aquamax, Oilatum, Zero cream are some that are listed on one of the NHS websites. So I hope that answers your question. Just refreshing to see if I have any more questions here. So, any advice to someone who has unbearable intense itching in the trunk area, back and chest, but no rash? What does one do to stop the itching and the dry skin that goes with it? Are they interrelated? This person's nervous about using steroid creams. So their itch is an interesting problem, as I'm sure, as itch has been linked to active disease in systemic sclerosis and morphoea. So certainly in some situations it will reflect that the inflammation and ongoing fibrosis that's in the skin is actually causing itch. And in that situation, probably the best treatment is going to be one which is going to treat the underlying disease. So being on something like mycophenolate, hydroxychloroquine, or possibly methotrexate, depending on what other complications you may have in relation to systemic sclerosis. There are a number of topical treatments, i.e. cream treatments that we use for itch, and increasingly there is a literature on new. So we've always thought of histamine as being linked to itch, but now we know that there are nerves that are responsible for itch messages coming from the skin, which are not linked to histamine. And we know that, for instance, endocannabinoids and various other systems are potentially involved. So there are a number of products now, actually, and I just have a crib sheet somewhere here. Here we go, which are available, which may have an anti-itch impact, which are different, using a sort of different mechanisms. So things containing polydocanol, which blocks or partially blocks something called the protein activase receptor 2 in the skin. And there's a range of those. So Eucerin products, the Derma capillaire Eucerin products for the scalp, if you have an itchy scalp, and Ducray Sentinel lotion also contains polydocanol. There are also products that contain things which can stimulate the cannabinoid receptors and which seem to have some impact on itch. So Stiefel makes something called Physiogel AI, so calming relief anti-itch cream, and various other products in that range. Bioderma makes a product called Atoderm, which also has things that are acting on cannabinoid receptors. And then menthol is also, this is something that we've been using for decades really for itch, and so 1% menthol creams that you can buy over the counter or online are also things that might help, and those generally sort of act and make things feel very cold, and so that sometimes helps to combat itch. But also they may sort of be acting on something called the transient receptor potential melastatin 8. It's just all very complex. So new receptors and new pathways for itch are being identified at the moment. And another one, of course, is IL-31. So this is a chemical messenger that is linked both to skin fibrosis and lung fibrosis and itch. And so there are now systemic treatments for that, which may be things that become more available in the field of scleroderma. They're being used at the moment more in things like eczema and atopic dermatitis, but that's something that may become something that is seen more commonly in use or maybe trialed in systemic sclerosis. Next question is, how do you deal with red spots that keep appearing on the face and other parts of the body, and can you stop them? So by red spots, I'm assuming in the context of systemic sclerosis that you mean the telangiectasies, so the little tiny dilated blood vessels that we see in the skin, quite commonly appearing. I don't, as far as I'm aware, there's no way of stopping them from coming if you have systemic sclerosis, but they are treatable with lasers, and the vascular lasers that we have, so pulse dye lasers, for instance, and also IPL treatments can be very effective for these little vascular dilated vessels of telangiectasies. So that's what I would recommend you had, and that those treatments are accessible for patients on the NHS in this country, as if they have a background diagnosis of systemic sclerosis. So that's something to potentially ask your GP to refer you to your local dermatology service for. Can massaging with skin tightening around joints, fingers, elbows, and knees, are there any oils, creams that you recommend? I think this is a question from Jyoti. So I presume you mean, can massaging help? So I think massaging is actually very useful. It helps to maintain a bit of mobility around joints, maintain a bit of mobility within the skin, and it's often quite soothing. It also helps to remove excess fluid from an extremity. So if you massage up your fingers and hands and wrists, etc., up the arm, that can help to reduce the amount of edema, and then so chronic edema can lead to fibrosis, and so if you can treat the edema on a regular basis, treat the fluid and get rid of some of the excess fluid in the skin, that can help to minimize the ongoing fibrosis. So it's an adjunctive treatment. It's not but it's something to be used early on in that context. But just generally massaging and keeping joints and limbs mobile is really important, because if you don't, they seize up, and so that can be part of the treatment. Oils and creams that I would recommend, I think anything that is moisturizing to some degree and provides sort of frictionless massage, if you like, will be helpful. I don't think there's anything specific that is advisable. So it's whatever you like, really. So Lizzie says, my son has had morphea from the age of 10 and he's now 16. Do you know if dietary changes can alter the progression of morphea? Any advice much appreciated. To my knowledge, there is no link between morphea and diet. Obviously, generally, balanced diet is good, and there is, everybody suggests really that having low vitamin D is not good if you have an inflammatory condition. So making sure that you have good vitamin D intake and oil intake and supplements for vitamin D is always good, but I don't think there's anything specific for diet in morphea. Okay, so I have a few questions here. So this is from Betty. My scleroderma is worsening, my feet are changing shape, and there doesn't seem to be room for all my toes. Sounds silly, but they become very sore. I wear compression knee-high stockings in the daytime, but when I remove them at bedtime, my feet begin to scream. Feel like the compression hosiery supports my skin in the daytime, but at night it's so uncomfortable. Sometimes it stings and my squashed up toes are very sore. GP gives me dermal cream, which I apply regularly. I can only wear certain shoes because my feet feel like I'm walking on stones. So, Betty, you have a problem which I think is not uncommon in systemic sclerosis, and a really difficult one, in that as there are changes that happen in the feet, which mean that you lose the fat pad on the soles of your feet, and it does become very uncomfortable. And you know, that walking on pebbles is something that people describe. I would definitely recommend that you saw a chiropodist, that you had your GP refer you. So there are often insoles and things that you can put into footwear which will make things a little bit more comfortable. And the other thing is also just wearing insoles that keep your feet warm, as well as support them during winter months. So those are two things to think about. And in terms of the pain and the compression hosiery, again, I think that's a difficult one, because compression hosiery can potentially, if it's too tight, upset the nerves in the skin. And so it may be that it's something to do with that the change in pressure on the skin that then causes a change in sort of nerve stimulation that causes you to feel like your feet are screaming. I'm assuming that you mean that it's a sort of crawling pins and needles-y sort of pain, or a burning pain, and that suggests something coming from the nerves in the skin potentially. So it may be that you need to review whether your compression hosiery needs to be made to measure if your feet are a slightly unusual shape, and or if they have suffered the consequences of changes due to the systemic sclerosis. So that, again, all of that could be assessed by chiropody, I would have thought. And in terms of the stockings, it may be that you could ask your GP to prescribe made-to-measure graduated below knee compression hosiery. I hope that answers your question. So Pamela has patches of scleroderma on the trunk and arms, and also around the neck. So she says that she was discharged 20 years ago, and it gets occasional itch and more irritation. She's asking if this is normal, and saying that some people are checked up on an annual basis. I'm a little bit unclear from what you're saying whether what you have is morphoea, where you've got patches and something that's confined to the skin, or whether you've got systemic sclerosis. I think from what you're saying, it sounds as though you may have morphoea because you've got patches in various places on the trunk and limbs and neck. That is a condition which can sometimes grumble or reactivate. And so if you are getting new patches, or your patches are becoming thicker or more symptomatic from sort of burning or itching sensations, then it is something that you should perhaps see your GP about and ask them to refer you, so that you could be assessed by your local dermatologist. And you know, it may be that you'd benefit from some treatment, either with a cream treatment or potentially some light treatment to try and switch it off if you have got active and ongoing morphoea, for instance. Sheila says, what's the best way to treat digital ulcers and fissures? I've been diagnosed with scleroderma for 5 years, and although I've improved, my fingers continue to have breakouts. So that's a very good question. So digital ulceration and fissuring is a real problem, obviously, in patients with systemic sclerosis. One of the main, so it's a combination of things. One of the main things is to treat the vascular problems that are linked to causing digital ulcers. So treating Raynaud's phenomenon optimally, and that means keeping your hands warm, drinking warm tea when you go out, using things like antioxidant vitamins and supplements, but also treatments, so medical treatments, so things like calcium channel blockers, so diltiazem and nifedipine are medicines that are probably the first line in many patients. Other possible things that we use losartan a lot, which is an angiotensin receptor blocker. So there are various different classes of drugs that can be used. The calcium channel blockers, the angiotensin receptor blockers, the fluoxetine SSRIs, which so you can use combinations of these medications to optimize treatment of your Raynaud's phenomenon. And then if there are ulcers that are not responding to that sort of treatment, then things like sildenafil would be the next thing to add in, and then admissions for iloprost or bosentan. So there are lots of different ways of escalating treatment for digital ulcers. In terms of keeping kind of fissures comfortable, so when you get cracks in the skin, one of the things that I find helpful is something called Lasser's paste, which is spelled LASSER apostrophe S, and it's something that is available online. It's not very easy to get in pharmacies, but one of the major constituents is zinc oxide paste, so you can also use that, and it just sits in the cracks and just seems to help with the pain that they cause, and slowly sort of improve healing as well sometimes. But it certainly makes them more comfortable. So I hope that answers your question. It's quite a stepwise progression for things like ulceration. Deborah, says that the skin on her hands has gone quite thin and she has little scabs appearing on them, and wants to know if it's related to her limited systemic sclerosis. She's also got lots of brown pigmentation on her arms and face. So a darkening of the skin is something that we see as a consequence of active inflammation in systemic sclerosis. It's also something that happens in the later stages of morphoea. So that change in pigmentation is something that we see very commonly. Sometimes it does resolve slowly over time, but often it is there and persists, unfortunately. So really the way of tackling that is to try and treat the underlying problem. And that usually involves tablet treatment. So i.e. the underlying systemic sclerosis. And in terms of the skin becoming thinner with small scabs, I suspect that the scabs are related to poor circulation. So similarly to what I was just talking about, really it's improving the circulation to the peripheries that will help with that. And the tablet treatments and things that I mentioned before. Lorraine says that she does her best to moisturize, but she finds that her skin's still very dry, whatever she uses. And so she's tried practically everything, and what's a good thing to use. And as I said before, really, there's lots and lots of different moisturizers around. The greasier paraffin-based ones are often very helpful in this sort of context if you've got, particularly on the lower legs, if you've got very dry skin, and around the ankles and on the feet. Flexitol Heel Balm is a quite high urea concentration containing cream, which is really good for feet, and also often I would use it on lower legs as well. Other high urea containing, so 10% urea lotions, and there are a variety of those on the market, and they're often very good at hydrating. So those are the things that I would generally recommend. So Caroline talks about her tight skin becoming itchy, and again, I think itching is probably linked to ongoing active disease in many situations. There are obviously some patients in whom itch may be linked to something completely different, and it may be that you have an other diagnosis, that you've got something like urticaria. So there are other things that could be happening at the same time, and that probably needs an evaluation by your GP to see whether or not there's something else that might help. We do sometimes give antihistamines, although as I mentioned, it's probably not just the histamine pathway. In fact, it's probably very little of the histamine pathway that's involved in causing itch in this condition. But you can try things like fexofenadine, which is a prescription-only one, or cetirizine, which you can buy over the counter at the chemist. And those are both non-sedating antihistamines, although occasionally they do cause sedation, so it's best to start taking them at night if you are going to try them. There's a tip here from Christine, who says that she has found Burt's Bees Honey Lip Balm the best, and I think that's a very useful reminder for me. So beeswax containing products are often very helpful. And keeping cool as well. So if you find that temperature change and being warmer makes you more itchy, then trying to keep your bedroom cool, and also trying the menthol containing creams and putting them in the fridge is often quite helpful. And Sarah says that she has significant skin issues on her scalp, face and ears, thick, itchy, white, yellow plaques and red patches on the scalp. And this spreads down onto the face and ears during a flare-up. And you get repeated ear infections due to broken skin. So your dermatologist appointment has been cancelled due to COVID, which is very frustrating, I'm sure, for you. What we're doing in the dermatology department at the Royal Free is we're getting patients to send in photographs so that we can do telephone consultations with the photographs and try and advise patients that way. So it may be worth finding out whether your local dermatologist is able to do that. In the meantime, this doesn't sound like the typical scalp changes that we would see in systemic sclerosis or morphoea. So I'm not sure that that's linked to an underlying scleroderma problem, but it could be that you have either eczema or psoriasis or dermatomyositis and an overlap autoimmune condition. And all of those would need some assessment really from a dermatologist. You could try one of those Dermocapillaire Eucerin shampoo products that's anti-itch. You could also try Nizoral shampoo, which is ketoconazole shampoo, and anti-yeast shampoo. Sometimes this kind of problem can be caused by yeasts that are on the skin and cause a sort of an inflammatory eczema-like reaction. And then you may need a steroid scalp preparation, which is something that would need to be prescribed for you. But I think you probably ought to at least have someone assess your skin before you go down that route. Let me see if I can find. So I think I have worked my way through most of the questions. Let me just see. So we've talked about itchy skin. A lot of the questions involve that. We have, oh, okay, so I have a question here about morphea. So I've had morphea from the age of 13 and I'm now 29. It calmed down for years, but when I became pregnant with my youngest, who's now 3, it got worse. And then when I went to the dermatologist, he gave me steroid cream, which I used for several months, but didn't feel it was working, so stopped it. I've noticed that it's getting worse and spreading around my leg and hardening. What would be the best treatment for this condition? So morphea certainly is known to reactivate under a number of circumstances, and post-pregnancy is one of them. That's quite well recognised. Probably topical treatments obviously are first-line treatments for morphea, but if that's not working, and if it's extending down a limb and or is a linear form of morphea, then we would generally recommend potentially a trial of light treatment first, but usually we would recommend tablet treatments for that, and hydroxychloroquine and methotrexate plus or minus some steroid tablets or infusions would be what we would normally use, depending on the severity and depth of involvement and extent. So that's something to see your local dermatologist about, really. Ask your GP for a referral. Let me just have a look here. Sorry, I'm back into... So somebody here is recommending using Cetaphil, which is oil-free. Cetaphil is a very nice, it's a nice range of products. They do a very gentle wash and a moisturizer. So I've got a message here from Una saying, do most dermatologists specialise in scleroderma? So the answer to that is probably no. I'm one of a few dermatologists in the UK who are interested in scleroderma. But there are a number of dermatologists who work with their rheumatologists locally and manage patients, especially with morphea, which is the more sort of skin-limited form of sclerosing skin disease. But a lot of dermatologists will have some experience, or there will be in departments, there will be a dermatologist who works with their rheumatologist and who may have some experience of systemic sclerosis as well. So I've got a patient, so Una's saying that she's in Northern Ireland. So I have seen 1 or 2 patients who've been referred from Northern Ireland. It was quite a challenge actually getting them across, and obviously at the moment travel is difficult and probably not recommended. But we are in the process of setting up video consultations, and we can do remote consultations with pictures. And so if you wanted shared care from with the Royal Free, I'm sure that would be feasible. And certainly at the moment it would be feasible in a sort of distanced virtual way, if that would be helpful. Sorry, let's just try and work my way up here. Sorry, let me just... Again, I'm just having trouble with my technology. Sorry about that. So I've got somebody here saying, I have primary Raynaud's. Please could you advise me if that puts me at more risk from coronavirus? So no, there's nothing to suggest that having primary Raynaud's would put you at greater risk of having coronavirus, as far as we are aware. It's not associated with any form of immunosuppression. If it is just hands and feet, then there's no reason to think that you would be at greater risk. It is worth actually mentioning in this context that one of the so COVID actually has a lot of skin manifestations. So a lot of patients with COVID get problems with their skin, and one of the things that we have been seeing a lot of in people who've had relatively mild disease is a while after, or towards a week or 2 after they've had a mild flu-like illness, they're getting chilblain-like lesions. And this has been happening around the world in summer months when it's been warm. And so we think it is a COVID-related problem. So new onset of chilblains that are particularly painful, and in somebody who's never had them before, it's something, it may be a sign of COVID infection. So that's just something to bear in mind. Obviously, that's not going to be the case for you, Mandy, but because it's something that is relatively short-lived and very much of the moment, if you like. But that is just something to make you aware of, particularly in the context of SRUK and people coming in with questions and issues about Raynaud's. I've got various people suggesting, so I've got dry skin, can't use greasy moisturizers because I'm working as a secretary. So I would recommend the Eucerin lotion, because I think that's actually, relatively speaking, a bit easier to use. There is also another product. So CeraVe is CeraVe cream is and lotion are products which are made by L'Oreal, I think. And they have been shown to improve skin barrier function, and they're quite easy to use, relatively non-greasy moisturizers. So that might be something that you could have a go with. I certainly managed to use CeraVe cream without too much trouble, although obviously you need to leave it a few minutes after using it before you start on a keyboard. Somebody's mentioned a very itchy rash on my right hand, and they've been using steroid creams in combination with antihistamine tablets, and it hasn't cleared in over 6 months. Now, the first thing that strikes me about that is it's one hand. So things that are inflammatory usually are symmetrical, or more often than not. So if you've got something that's on one side only and one hand only, and is an itchy skin rash, I would wonder about whether you've got a skin fungal infection, so a type of ringworm. So I would see your GP, ask them to do some skin scrapings, and potentially trial Lamisil cream, which is terbinafine cream, which you can get in England anyway. You can get that over the counter without a prescription at the chemist. So I don't know whether that's the same in Northern Ireland, but worth considering that as a possibility rather than it being an inflammatory skin problem. Somebody here has been mentioning amitriptyline for itch and to help sleep. So there are various, that's a very good point. There are various nerve stabilizers that we use in people who have itch. Amitriptyline is one of them, and 10 milligrams at night is often very helpful. There are, so pregabalin and gabapentin are others, which they're all prescription medicines, so you would need to see your GP, but those things might be helpful. Let's just move up. So somebody, Sam, has itching on her knees and elbows with tiny bumps that come and go. Can't sleep, it's so itchy, it comes and goes every few months. Worst it's ever been, what can I use to help? Tiny bumps that come and go. So if they're coming and going within a few hours, so one goes and another one comes up, that might be a type of urticaria. A bit difficult without any more information. But it might be worth trying an antihistamine. So you could try something like Piriton, which will also, it is a sedating antihistamine, so it may make you a little bit more drowsy, so it might help you to sleep and relieve the itch at the same time. So that might be one possible option. If it's not settling down, I would ask your GP or take some photographs of it and show them to your GP. Okay, so this is for Betty. It says, I have to wear full-on compression leggings as I also have lipedema and have the same pain in my feet and toes. Saying your feet scream is exactly how I describe my pain too. I wear Skechers memory foam trainers and Adidas cloud foam trainers. They have lots of cushioning, might help until you can get a referral. So there was some advice about what to do for those painful feet. And there's, you're all giving each other advice here, so that's I'm impressed. So shoe liners and soles, which make all the difference for those sort of painful feet that feel like you're walking on pebbles, and you can get various different thickness and thermal ones from Boots and Superdrug and Craggs shoe repairers. I think they may be in Leeds. So this says there should be a community, so Chris is saying there should be a community dermatologist in your area who might come to your house. I'm not aware of that, certainly in my area locally, but we do have community dermatology services, but they tend to be in clinics within a community setting, and at the moment they're operating apart from for emergencies, so we are all seeing patients with emergency dermatology problems, but as anything that's not an emergency we are trying to manage virtually, i.e. with photographs and telephone or video consultations. So there's another question here about darkening of the skin. And I think all of that is if you have systemic sclerosis, it's not an uncommon problem to get skin darkening, and you just look very tanned often, is how people describe it. It is something that does tend to, my experience of it is it takes a few years usually, but as the skin thickening and tightening evolves and softens, which it does in a good proportion of patients, that pigmentary change also seems to improve. But it's not a quick thing. It does take a number of years. And there's no, I can't guarantee, because there are some patients whose skin remains thick, and in that situation it tends to stay darker. Just trying to see if there's any other questions. Somebody's suggesting a Raynaud lotion for as a relatively non-greasy moisturizer, and vitamin E dry body oil, which is a vitamin E containing product, which may well be helpful. So somebody here, so Lindsay says she has mixed connective tissue disease with Raynaud's. It's very itchy and she has damaged skin on her lower legs, and she wants to know if that's linked to this form of the disease. It also spreads to my forearms, especially the elbows. Tricky question to answer, that one. Dry skin, I mean, this also could be if you've got something going on in your elbow flexures and on the lower legs, it could be that it's a different problem and that you've got a bit of mild eczema. I would recommend, I mean, either way, I would recommend that you use a regular moisturizer, and it may be that you need one of the heavier ones that we described earlier. It's probably worth actually having somebody look at it and decide what they think the skin diagnosis is, because it depends on what elements of what mix there is in your mixed connective tissue disease, to understand whether or not it's linked to what's going on in your skin. Prevention of digital ulcers. Well, we did touch on that earlier. I think the most important thing probably is a regular either calcium channel blocker or angiotensin receptor blocker or something like fluoxetine. There's some evidence that fluoxetine is particularly helpful in primary Raynaud's, but it's also, we use it a lot in secondary as well, but that might be more first line in primary. So Rhonda says that she has Raynaud's phenomenon and her feet have very thick skin, especially on the tips of my toes and on my heels. Toes, they're hard and thick, hard, thick skin, tend to get them bladed off. So she's also on rivaroxaban because of previous thromboses, and so I don't think that makes a difference to the thick skin. Obviously, having things bladed off might you might bleed if you're not careful, if they're not particularly, depending on who's doing it. So obviously that needs to be done with care. I usually recommend things like Flexitol Heel Balm, which is this really sort of strong urea cream, which is good for heels and feet. The other thing would be something called propylene glycol, which is something which helps to take off the thick skin, and it is a prescription treatment, so you would need to see a dermatologist for that. But we can certainly try that. And also things which improve the circulation. So again, treatment for the Raynaud's will help the blood supply to the skin, which will probably have some impact on that thickening. It certainly seems to, although I don't know the pathophysiology behind that. So somebody's asking about sunscreens, and we usually recommend sunscreens that have good UVA and UVB coverage. So the SPF, so SPF 50, it reflects the level of protection against UVB, and the UVA protection is a different. It's a different measurement. So it's often a star rating. So you may see on the back of your sunscreen a number of stars that have filled out, and you want 4 or 5 star UVA protection. Not all sunscreens kind of explain exactly how what level of UVA protection they have, but Anthelios XL products and Altruist, which is an online sunscreen which has 5-star UVA protection and is an SPF 50. So those are the, along with SunSense, those are the sunscreens that we tend to recommend, certainly in my dermatology department. But again, it's finding the one that suits you, as long as it has good coverage for UVA and UVB. So I've got a question here about fat transfer, I think. Fat transfer and fillers. So there is there's a big tradition, if you like, at the Royal Free. We have a consultant plastic surgeon who has been doing fat transfers in patients with scleroderma for a number of years, and so we are quite pro fat transfer to both fill defects in patients with morphoea and atrophy, so hemifacial atrophy, so dips on the skin of the skin and soft tissues of the face due to tissue loss. But there is also a school of thought that injecting the stem cells from fat into around the mouth, for instance, in patients with systemic sclerosis, can help to free up that sort of bound down difficulty with mouth opening, and so there is a literature that's evolving on that. So that might be something. I mean, I'm on the whole, I would recommend fat transfers. In morphea, I usually try and make sure that people have inactive disease, because if you put fat into somebody who has got active morphea, then it's likely that the problem will just recur. They often don't last forever, and sometimes the appearances that you have in the early stages it can be overfilled and then gradually change. So it is variable in terms of the outcome, but as I say, on the whole, I would recommend it as long as the sort of it's right for the particular patient. So it needs assessment basically, and it's not one size fits all. So I have somebody here, Heather, saying that she has scleroderma. So I presume she has morphea, which affects her left hand. Skin's really thin on the hand particularly. And is there anything she can use to improve that? So that is the difficulty with morphea, is that, you know, one of the reasons we try and treat it reasonably aggressively is that once you lose tissue, you can't grow it back. Fat transfer sometimes helps if it's it sometimes helps just to sort of bulk out so that things are not quite as uncomfortable when you're using your hand. But I'm not sure that there's anything else that would actually thicken. Well, there isn't anything else that would actually thicken the skin as such, or replace the soft tissues that have been lost, I'm afraid. What's your opinion about having systemic scleroderma with all negative tests? So by that, I assume that you mean that you've got no antibodies. So none of the kind of typical antibodies that we see normally in systemic sclerosis. This is something that we recognize. Usually, I would call that a sort of atypical systemic sclerosis in the sense that it's not fulfilling all the kind of typical criteria. We generally, you know, it's clear that there are people who present with systemic sclerosis who don't have antibodies. It does happen, in the same way that sometimes patients present with antibodies and no skin thickening. So it's a variable thing. But I would always check scans in patients who have no antibodies. So I'd always do CT scans of the chest, abdomen, and pelvis, and just do a sort of full check to make sure that everything else is okay. So that would be my thought on that one. Sorry, just scrolling up looking for questions. Okay, let me just have a little look and see if I have any more. So no, I think I've answered all the questions that have been sent to me. Let me just have a double check again. Oh, somebody said hotter shoes are good. That's true. They're quite comfortable shoes. And someone's talking about bamboo socks, which have thicker soles and soft tops. The other thing to talk about, just to mention in context of Raynaud's, is the silver socks, because they seem to help retain heat. And obviously the heat pads that you can put in your gloves and things. And the only other thing, the other treatment that I didn't mention for Raynaud's actually, which is quite a good surgical treatment, is Botox. So Botox injected in the interdigital spaces can open up the blood vessels in the fingers and help with Raynaud. So that's another possible option to try, perhaps before some of the hospital infusions. So what have I got here? So Mandy has asked about the laser treatment. So I mentioned IPL and pulsed dye laser, which is one of the classical vascular lasers that we use in dermatology. So that's the other one. So Mandy's asked about stretch marks, and I'm afraid I have no magic for that. In terms of prevention, things like sort of moisturization and almond oil are said to help, but whether, I mean, there's no real evidence as far as I'm aware. There are some lasers that are reported to improve stretch marks, but I'm afraid I don't know the details of those, nor have I read the literature on it. But that might be something to ask a laser dermatologist about. Let me see. Does a normal capillaroscopy exclude scleroderma even if other signs are there? Well, that's an interesting question. It's not a totally skin-related one. So normal capillaroscopy would be unusual in the context of systemic sclerosis. If you have widespread skin thickening with normal capillaroscopy and no involvement of your fingers, then I would be wondering if you had pansclerotic morphea rather than systemic sclerosis. So that would be my initial thought on that. But obviously, I'm not sure of your what the other signs you're talking about are. So the other signs, if you had systemic sclerosis antibodies and lung involvement, it would be unusual for the capillaroscopy to be normal, I would say, actually. So I think that perhaps needs a little bit more thought and perhaps review by your doctor. I've got a message here which just says calcinosis on the skin. Yes. Calcinosis is a tricky one. It's probably one of the most difficult things to manage in terms of skin signs in systemic sclerosis. Very, very rarely we see it in patients with long-standing linear morphea as well, but it's really mostly patients with systemic sclerosis who get calcinosis. So there was a meta-analysis in the last year, I think, of treatments for calcinosis, and what they came up with was A, there's not very much in the way of study on calcinosis, and B, what seemed to be the most effective thing was the use of calcium channel blockers. So drugs like diltiazem seem to make a difference in terms of the development of calcinosis. Obviously, if you have extensive calcinosis, it's very, very difficult to reverse. If there's small bits of calcinosis, sometimes taking them out surgically with a curette can help, but obviously that leaves a hole which then has to heal, and depending on where that is, if it's extremities, then that sometimes takes a long time. So it's a very difficult problem. I think improving the circulation generally may help to minimize the development of calcinosis. So if early on in the course of your condition you use things to keep your blood vessels open, that may help minimize the development of calcinosis. It's a tricky one, and I'm sorry I don't really have a magic bullet for that one at all. Okay, somebody said silver socks don't work, horrible things. So clearly, it's some people like it's a bit like Marmite. You either love or you hate it. Okay, somebody's mentioned the self-heating insoles available at the SR UK shop, which work well. So that's something to consider. Sorry, let me just. So yes, Chris, sorry, yeah, the calcinosis. I think just trying to maintain circulation and keep your hands warm will help prevent the ulceration, hopefully. Got a message here. This is from, I think, from the, let me just, this is from Matilda, who may have been the person who was asking me about, yes, normal capillaroscopy. So she says, oh, I seem to have lost her message there. Where's it gone? I've lost it. But anyway, she did have lots of symptoms and signs suggestive of systemic sclerosis despite normal capillaroscopy. Okay. Any other questions or comments? Okay. I think Matilda, I've got your message. Don't worry. Okay, I think that probably concludes our session. Sorry, message from Chris saying I use hot hands warmers if I'm on a scooter or in a cool place in gloves and boots. Yeah, and the other thing obviously to be cautious about is when you go into the supermarket, into the cold counter, make sure you've got something to keep your hands warm then. But you probably all know that better than I do. Okay. All right, well, I guess this is where I sign off. Thank you very much for your participation and your questions, and thank you very much to SR UK for asking me to do this. And I do hope it was helpful. Thank you very much.